Thanks again for the opportunity to be here. It is a pleasure to not only be out and about, to be able to see people, but also debate. Roxana, who Dr. Maran is a leader in this area, so I will try to do it justice. These are my disclosures. So rules of engagement for a debate, I feel like I'm going against conventional wisdom these days. I'll take about 7 minutes and make 5 points. I think you're going to see some of the same studies and slides. And so when you see the same data and people are debating, it's just a question sometimes about how you interpret the information. And sometimes you'll see the same. You could take either sets of slides, I suspect. So let's agree on why we do things for patients. It sounds crazy for the debate, but it's to make them feel better, improve their quality of life, reduce symptoms, improve well-being. To avoid unpleasant events, we could say that's hospitals, MI, stroke, limb loss, potentially some sorts of bleeding that might get you to the hospital, to make you live longer. Dr. Califf told me that in the Duke CCU in 1997. I've added the 2021 edition, or you could have said even before then. Save them money, similar outcomes with less cost. So theoretically, when we're having a debate about what somebody should be on for antiplatelet therapy chronically with coronary disease, that should potentially play a role. I think it's hard to argue that the evidence today says a reduction in the duration or intensity of antiplatelet therapy is a winning strategy. In fact, one could argue we got here because we had a concern after drug-coated drug-eluting stents that we would need dual antiplatelet therapy forever after late stent thrombosis, but with second and third generation devices, that may not be the case. But if we weren't thinking about a stent, what would the evidence be for antiplatelet therapy? So here's the main theme, I think. If you're thinking about a patient with cardiovascular disease, we're moving from a platelet-centric world to a less antiplatelet-centric world, and maybe a better antithrombotic world. Chronic CAD, and I'll just remind us that we've studied monotherapy aspirin versus clopidogrel. And we've now seen monotherapy ticagrelor and clopidogrel post-stenting in the last year. Dual antiplatelet therapy, I'm sorry, I shouldn't say monotherapy, dual antiplatelet therapy. And then it's worth recognizing before the DAPT trial, there was the CHARISMA trial, chronically looking at aspirin and clopidogrel versus aspirin. And then recently we've had the DAPT study, the antithrombotic therapies with low-dose rivaroxaban and post-PVD, and I'll talk about some of the ACS data too. So here's CAPRIE. 3 years, 19,000 patients, now 20 years old, published in Lancet in 1996. Clopidogrel chronically was better than aspirin, but it was about 0.5% absolute risk reduction better than aspirin. At that time, clopidogrel was very expensive and did not get chosen as the monotherapy. Aspirin did. So since then, we've gotten new antiplatelet therapies, ticagrelor, prasugrel, others. The idea that you would change one of those out for aspirin is the sense of this debate, and I start with what clopidogrel gives you, which is real and certainly an important advantage, but a small one. You would have to treat upwards of 220 patients chronically to see one reduction in event. How about 2 drugs versus 1? This is aspirin and clopidogrel versus aspirin alone, again in chronic vascular disease after stenting, following patients greater than 1.5 years to 2 years after an MI. Again, this event rate was 0.5%, 18,000 patients. There were some diabetic patients in here. This did have increased bleeding with the dual antiplatelet therapy. Looking at actually gusto moderate bleeding, significantly increased. So I would say 2 versus 1, similar efficacy in charisma, increase in bleeding, probably still just stay with aspirin. Roxana Moran has presented these wonderful data published in the New England Journal. How about dropping aspirin? This trial, as you all know, and other data that have now been published, as you've also done with Xience, stopping the aspirin either at stopping 2 therapies. We'll talk about what you stop at 3 months here, the ticagrelor and aspirin arm versus ticagrelor and placebo, dropping the aspirin and following these patients. And a compelling finding in a reduction in bleeding, BARC 3 and 5, you can see a 1% reduction. Gusto moderate or severe, you can see about a 0.7% reduction. You can put that into the DAPT sort of perspective I just showed you with charisma. And here's the key secondary endpoint of death, MI, or stroke, things that would bring the patient to the hospital, having events. Again, very similar rates between the two. So no harm dropping aspirin potentially, but aspirin versus ticagrelor. And I said compelling with a mild reduction in potency, dropping aspirin rather than dropping the P2Y12. A high bleeding risk, high PCI patient, risk patients, but the event rates were still somewhat low, I think, likely due to randomization at 3 months. Point 4, here's the overall weight of available data. To date, all the studies on top are the ones where there's 3 versus 6 or 6 versus 12. All of them in the DAPT design, at least at that point, was dropping the P2Y12 and keeping the aspirin going. The below aren't all the studies. You're going to see some more probably with some of the stents and others, and that's aspirin discontinuation. And here's some more of those that you can see again with different durations of aspirin. But the take home for me is it's pretty clear 2's not better than 1. The debate is just which one do you continue on? Ticagrelor versus aspirin. If you drop aspirin, then you're saying I'm going to give one of the stronger agents long term. Well, what is the monotherapy standard of choice? I think it's the one the patient can take. And at the end of the day, what can the patient get and take? And so you've seen these several sets of updated guidelines, many of which have posted and said at some point you can stop. I think even now at ESC, there'll be another trial potentially that'll have data for us on DAPT-1 versus 3 months after after stent. And after ACS, as you've seen, even out to 1 year, if you can keep the ticagrelor going and dropping the aspirin, doesn't seem to be harmful. So I think we're probably debating on the same side of the street, probably. We're saying, yes, you don't need dual antiplatelet therapy, and the antiplatelet you should use might be ticagrelor or aspirin, and the decision might be based on patient risk. So I'll start by putting it together this way. It's generally clear in our platelet-centric world, the world has changed. DAPT in general for long duration with 2nd and 3rd generation stents is not needed. Even in ACS, DAPT duration might be shorter. Shorter duration is now being evaluated 1 versus 3 months. I told you that master DAPT might be at ESC and others. We've seen other studies like this with STOP-DAP2. We've also seen it with some of the stent studies. I believe likely aspirin or clopidogrel, now that it's generic, stays long-term monotherapy due to the dose knowledge we have, knowing the chronic dose of that therapy, the ongoing evidence, and the price to the patient. So like all procedures and decisions, who knows what the right one is? You're going to have to personalize it for each of your patients, but thanks for the opportunity to have this debate.